Good morning, and welcome back to our session 2. I'm picking up here for Dr. Kaiser, and am going to be leading this session, which is entitled Strategic Considerations for Conceptualizing Access. I'm Andy Beinman. I'm from the University of California, San Francisco. I'll be moderating this session, and I have an outstanding panel of speakers who are going to lead this session. This session, picking up from session 1, is really getting into the issues of how to further think about the conceptualization of access. And as we thought about it and we're putting together this meeting, we really wanted to think about going through these concepts as a way to then set up an opportunity in the next session to get into more of the operational issues related to defining access to care. Some of the issues that we will touch on in this session have to do with the frameworks that exist for measuring access, thinking about how those frameworks are unique to high risk or vulnerable populations, as was already raised in the last session. I'm going to start by introducing our first speaker. I want to say that the bios for all of the speakers at our meeting today is available in the materials for the conference. You can click and find that. I'm not going to go into depth on introducing each of the speakers because that information is there. But let me first welcome to the podium Lillian Gelberg. Dr. Gelberg is a professor in the Department of Family Medicine at the UCLA David Geffen School of Medicine at UCLA and the Department of Health Policy and Management at the UCLA Fielding School of Public Health. She's also a part of the VA Greater Los Angeles healthcare system. So, Dr. Gelberg, please, we look forward to your presentation.
Great. Thank you so much, Andy. And thank you to the National Academy staff and to Ken Kaiser for all their hard work and the committee for planning this. So let's see if the slides are, there we go. So I wanted to talk to you about applying the behavioral model for health services utilization to the veteran population. And I want to acknowledge my wonderful colleague of 30 years, Ron Anderson, and he and I worked on this together. Aims are to review the behavioral model as a conceptual framework for analyzing access to care for veterans, to describe the dimensions of access to care, and to show examples of how to apply the behavioral model to improving access to care for veterans experiencing homelessness. Why should we care about access to care and about veteran-centered care? Well, the National Academy for Monitoring Access to Medical Care defined effective access, not just for access in and of itself, but because it would achieve the best possible health outcomes. Let's see. There we go. Whoops. How do we define access? Well, it's the actual use of personal health services and everything that facilitates or impedes that use. It's the link between health services systems and the populations they serve. Access and the conceptualization and measurement of it is really important for predicting health services use, promoting social justice, and improving health outcomes. So, aim 1. Here's our behavioral model, and I'll walk you through it a little bit. And I don't know if my arrow shows, but here are contextual characteristics. So these are the characteristics of the healthcare system, the environment, its policy, organization, it's the demographics of the community and their social supports, their health beliefs, environmental health, and then population health indices. And then we go into the individual characteristics, which I'll define of the veterans, which all impact their health behaviors, their own personal health practices, the processes of medical care, including patient-centeredness, the theme of this conference, and use of services. Here's the goal in the big yellow box: improving veterans' health, their consumer satisfaction, quality of life, and really in here, provider satisfaction. We adapted this model for vulnerable populations in 2000, and both of these models have been used extensively for understanding access to care for veterans. There are contextual and individual characteristics, as we spoke about. The predisposing characteristics are those that pre-exist in veterans to use or not use services. Enabling conditions facilitate or impede their use, and need is really their health. It's what requires medical treatment. Here's some examples of contextual characteristics. So in predisposing would be the demographics and poverty of the surrounding community. Enabling would be, is that organization supportive of healthcare, and what is the process of care in that organization, and who's leading that organization? And then the need, we talked about population health and environmental health. For individual characteristics, predisposing characteristics include demographics like racial ethnic disparities, aging, LGBTQ status, poverty, homelessness. Enabling characteristics are service connectedness. These are factors that enable veterans to get care, social support, transportation, housing, and need. We talked about multimorbidity, PTSD, military, sexual trauma, just for some examples. Improving access to care for veterans must also consider that health behaviors can impede or facilitate use of health services. So these health behaviors include use of services as an outcome, process of care, and personal health practices. By use of services, we mean it broadly. All the different types of health services. The care can be synchronous, it can be asynchronous, and in this era of COVID, it's very important because of the asynchronous care being really important with telehealth today. The process of healthcare, this is what we talk about, patient-centeredness, or what we now call it is veteran-led care. It's not this big infrastructure to support the veterans. It is veterans leading that infrastructure. Care determined by and for the veteran, care and outcomes tailored to veteran preferences. And then personal health practices are the positive personal health practices and some of the less positive personal health practices. And the process of care and these personal health practices are important because they help us to understand health services utilization. So now, dimensions of access. We've been talking about how do we define it. What is access? It's use of services and everything that facilitates or impedes that use. But there's potential access, which is the enabling characteristics that affect that use. And then there's realized access, their actual use of services. There's equitable access. Are people getting access to care that's predicted by their age, their demographics, their genetics, and their need for healthcare? Or is it inequitable? And then it would be predicted by their social and enabling characteristics and vulnerabilities, such as homelessness, being older, racial ethnic disparities. Effective access is access that improves outcomes. And efficient access is access that improves outcomes and minimizes cost. Access to care matters, as we talked about, because it impacts veterans' outcomes. And we talked about some of those outcomes, their health, both how they perceive of their health as well as how we evaluate it, their satisfaction with care, their quality of life, and all of the domains of quality of life, and housing stability. I'd now like to give you some examples of how we have applied the behavioral model to improving access to veterans experiencing homelessness. And I'm going to give you 3 examples that we've developed at GLA, the Greater Los Angeles Healthcare System. We now have a tent community, we've got an interprofessional care team, and our Humanism Pocket Tool. So first, I want to tell you about Something positive that's come out of COVID, LA has the largest unsheltered homeless population in the US. And the COVID pandemic prompted our GLA leadership to create a safe environment for veterans experiencing homelessness to shelter in place. We now have 50 tents on 2 parking lots, and this will soon be growing to 200 tents where the veterans experiencing homelessness shelter in place, and it increases access because we provide care to the veterans right there and give them housing services. It's the first of its kind program, and I'm really proud of it. It's called the Care Treatment and Rehab Service, provides immediate shelter to tents on VA land. This is on our Greater Los Angeles VA property. It's got integrated services for housing, hygiene right on site, health, food, primary care, peer support, and social services. So how does the behavioral model apply here? Well, we have altered the contextual characteristics. Our leadership made a decision. We changed the organization of care. The environment is now different for COVID. We have tested 1 person positive for COVID in contrast to other environments. And so the population health has improved and the environment has improved because they have places where they can wash up and go to the bathroom. The individual characteristics have been improved by that. Their personal health practices can improve because they've got COVID hygiene stations and showers, and they have masks, and we bring healthcare to them. And so they're very happy. 80% are happy with or more with this setup, and their quality of life is improved, and the providers love providing healthcare there. We also developed an interprofessional team-based care called our IAH Pact. It's a Center of Excellence, Interprofessional Academic Homeless Patient Aligned Care Team. How's that for a mouthful? It's a one-stop shop for homeless veterans. It's a model for medical training programs on homeless healthcare, and our trainees in all of these various interprofessional professions want to stay at the VA. They love practicing medicine. The patients love being cared for there. Many of them have said that this is the most satisfying healthcare setting they've ever worked in. And we partner very closely with community partnerships and engage them. And then we have, as part of our IAH Pact, we developed the Humanism Pocket Tool, a veteran-centered process of care. So veterans may be able to access care, they may be able to make a healthcare visit, but they may not be able to return, or they may not want to return for follow-up visits, especially those who've got complicated needs if their provider is rushed, not kind, not compassionate, or not veteran-centered. But veterans are excited to return if we provide them with the concierge care tailored to their needs. Their healthcare provider shows warmth, expertise, optimism, veteran-centeredness, supported by our Humanism Pocket Tool. The healthcare provider feels supported in being able to do this for these extremely complicated veterans who are providing care as part of an interprofessional team. So here's what let's go down. There we go. Whoops. There's our pocket tool. So coach yourself toward a caring frame of mind. Be warm, listen actively, and be curious. Create a vivid vignette. Ask the veterans, what matters to you? What brings you joy and what gets in the way? Get the veterans' obstacles and aspirations. And for their chief complaint, you begin right away by saying, this is a 35-year-old Marine Corps veteran studying to be a pastor, but haunted by an Iraqi torture chamber. Instead of saying, this is a 35-year-old veteran who is a methamphetamine addict and is having a hard time with his uncontrolled diabetes and hypertension. You can see how that completely changes the frame of how these veterans will perceive their care and if they want to come back. Use the vivid vignette to inspire and coordinate care. During interprofessional meetings, listen actively and appreciate differences, and know your colleagues as people. Try this. On Monday mornings, check in with some of your team members by asking them, how was your weekend? This will help you to know them better. If the team is happy, they will be providing better care to veterans. So the summary, using the behavioral model, we get an understanding of how veteran-centered care or veteran-led care, structures and processes of care tailored to the needs of veterans, enables them to access care and improves their outcomes because of the care they received. Thank you.
Thank you very much, Dr. Gelberg. That was tremendous, and really appreciate not only the very comprehensive presentation on a framework for thinking about the concept of access, but how it is specifically tailored and can be thought about for the VA population.